Okay, well, it's 3 o'clock. Good afternoon. I've lost the participants. There's now over 1,000 people online joining us. Sorry to make you anxious, Julie. And yeah, so just to say welcome to all of you. I'm David Murphy. I'm the current president of the British Psychological Society. And we're here for the next 45 minutes to talk about psychological aspects of well-being in staff who are involved in the front line of the COVID crisis. We'll introduce ourselves in a minute and then do an brief introduction to all of you, not by going round, but by doing a poll and trying to find out a bit about who you are. But I'll start off with an apology, because there's 1,000 people who are online, but there's about 2,000 people who signed up who are not online currently live. Those people will be watching it again on demand. So just to apologise for those people that you couldn't join live, but you'll be able to see the same thing, and you'll be able to fast forward the bits with me that are probably less interesting than the bits with Julie. So I should say that perhaps I should share my screen now. That would be a good time to do it. If I can share the screen and from the beginning. Okay, so now we've got the slides up. So we've got a hashtag if people want to live tweet or tweet after the event. The hashtag we came up with was C19 staff wellbeing. So that's the two of us, a bit bigger pictures of the two of us. I look better from a distance. That's probably even further than that. So I'm the 2019-20 president of the British Psychological Society. I'm a clinical psychologist, and it's my great privilege to hold that position, particularly at such a time of challenge. My background is actually coincidentally as a clinical psychologist, and for most of my 30-year career, I've been working as a clinical psychologist in acute hospital settings. I started life working in spinal injuries and worked across various medical specialties, and then was head of psychology services at Imperial College Healthcare in London for many years, and also the psychology lead for teaching medical students. And then I moved into clinical psychology training in Oxford, and currently I'm doing research on clinical leadership alongside being BPS president. I'll just let Julie introduce herself.
Hello everyone, so I'm Julie Highfield. I'm currently a consultant clinical psychologist in ICU, both adult and paediatric intensive care. I've been doing some work for quite some years now with the Intensive Care Society and staff wellbeing, and it's a core part of my role, but I've always worked in medical settings, and now in this COVID pandemic, the coronavirus pandemic, what I've now been involved in is this work with the BPS, but also the National Emergency Critical Care Group. So I'm the lead for staff wellbeing for that as well. So many strings to my bow to kind of prepare me for this work.
And the other people that you see in the boxes there, Thomas, Catherine and Helen are members of BPS staff. Teresa is another member of the Guidance Development Group who will come into life when we deal with the Q&A. So the plan of action is Julie and I are going to talk through the guidance and a bit of background to the guidance for hopefully about 25 minutes, and then that should leave about 20 minutes for questions. And the question and answer feature is open now, so you can start asking questions. Given that there's 1,000 people, I suspect there'll be quite a lot of questions. So the other thing to do is upvote questions that seem relevant or sort of similar to the sort of thing you're wanting to know, so that we can respond to the questions that are most sort of common to people. So at that point, I don't know, Thomas, if you can open the poll. So rather than going around and introducing each of you, we thought we'd do a poll to try and just get an idea of who's online. So are you able to activate that, Thomas?
That's activated for you, David.
Okay, great. So we'll run that, and hopefully it's not going to be too distracting for people if we carry on and just run that poll while we're going on. So I'll just put this tiny bit into context. So the BPS has got a coordinating group looking at our response to the COVID crisis. And I meant to say actually that for those of you who don't know, the British Psychological Society, we're the professional body and learned society for psychology in the United Kingdom, and sort of made up of 60,000 members, ranging from undergraduate students to people in academic research roles, practitioner psychologists, and people who've done psychology degrees and are applying it in different ways in different roles. So within that, there's a huge resource, I think, to bring to try and make a positive contribution to the COVID crisis. And this is the sort of map. It started off life as a handwritten drawing that I posted on Twitter and got a huge response. Actually, there's an article in next month's Psychologist magazine that explains a bit about that and how the groups got together, if you're interested. But I'm not going to go through all of this, but this is how we're looking at our sort of response and our contribution really to trying to help in the COVID crisis and make a positive contribution. And really, you can see that there's a number of aspects that are specifically related to COVID itself and the kind of consequences, direct consequences that we're looking at. And this work we're talking about today falls in within that, the sort of effect of COVID and the burden on healthcare staff and how we can consider psychological needs in relation to that. But also there's another side of it, which is the wider professional the professional impact, but also wider society impact. So having to work differently as it's particularly psychologists, but also other professionals, and also the effects on people in general. And within our work, which hasn't been sort of illustrated in this diagram yet, but I really want to make this point, we're really very conscious of the equity sort of aspects of COVID and how this crisis has really exacerbated existing sort of inequities in society, and so inclusion and diversity is a very strong theme that we're trying to, well, we are including in all of our work streams. So I just wanted to make that point. And so within this staff support group, we have produced this guidance that was launched on Tuesday, and that came into being, we drew on a guidance development group. We identified the impact of the sort of demand on the health service and healthcare staff of COVID would be a significant challenge. And, you know, we were thinking about how psychology could inform responding to that challenge. And you'll see in the guidance, there's a sort of list of practical suggestions. Oh, that's the bit I should have mentioned. At the top of your screens, that's the BPS COVID resource page. So our report, this report is on that page along with other bits of useful information. So even if you can catch that, the BPS website has a link right on its front page. So within this work stream, we pulled together a group that didn't exist this time last week, and we were able to draw on resources from really all over to bring together a group of experts, both from within the UK and internationally, to really try and distill down what psychology can contribute to this particular aspect of protecting and psychological well-being. And there's a picture of the group in action that last Saturday. So the group was been very busy over the weekend producing this guidance. And I just want to say, I mean, this is a panel of real experts in the field, and we were able to draw on some incredibly very generous colleagues from a range of disciplines. Bob Mander is a psychiatrist. Katie Scales is a critical care nurse consultant who I had worked with some years ago and hadn't seen for a while, but volunteered to help with this. So this is, I think, bringing these perspectives together has produced some really helpful guidance. But I should say there are other experts out there. So we're not saying that this is the be all and end all, but we're trying to put this together in order to give something that's helpful to people who are involved in frontline care or psychologists who are contributing to that group. I don't know if you want to say anything else there, Julie?
No, just the huge effort and energy that was put in this this typical COVID timeframe. So thanks to everyone who contributed, because it took quite an effort to turn it around so quickly.
Yeah, well, I'll take the opportunity to thank you, Julie, because Julie's been juggling this with lots of other demands on her plate. I just want to, I'm not going to go through the background to all the research. In fact, in the guidance, well, actually on the end of the slides, we've put some references that you can do that, because we didn't want to take up too much time doing this. But I just want to make the point that we can actually draw on quite a lot of background knowledge to inform how we go forward with coping with COVID. I mean, I'm going to focus on the sort of epidemic outbreak type literature, but of course we do know a lot about health service staff coping in challenging circumstances, which, you know, happens quite regularly. So, you know, I think there is a lot to draw on from other literature about stress and burnout in healthcare staff, and you know, this isn't obvious. This is a different kind of challenge that we're facing in sort of intensity and duration, but we do know there is literature to draw on. But I'll just briefly focus now on what we know about sort of similar disease outbreaks. And in 2003 there was a outbreak, as many of you remember, of Sars, another coronavirus variant, which was particularly affected Toronto in Canada. And the psychiatrist who was a member of our panel, Bob Mander, was carried out a research study looking at the effect of the SARS outbreak on health service staff. And the location of the outbreak was restricted to Toronto. So 9 hospitals in Toronto treated 500 SARS patients over a period of months. And what they did was compare those healthcare staffs who had had experience of caring for the SARS patients with nearby 50 kilometres away Hamilton Hospital, which didn't receive any SARS patients. And they followed the staff up 1 to 2 years later. And what they found was quite significant differences within the two groups. And I mean, it's probably worth just bearing in mind that those other staff were probably sort of in the kind of prepared stage to contribute to the SARS outbreak. So they will have experienced some degree of consequences of the outbreak themselves. But what was found was that there were significantly higher levels of burnout in the Toronto staff, who were primarily nurses. I think about 70% were nurses. 30% were over the threshold on the Maslach burnout inventory, and psychological distress was significantly higher, and post-traumatic stress, and 14% were over the threshold of 26 on the impact of event scale. It's also relevant when we come on to talk about the effects of psychological stress to note that there was a report of behaviour change, other sort of consequences. So over 20% of the Toronto staff reported increased smoking and alcohol intake, and I think that was compared to about 8% of the Hamilton staff. There were much more, again, 20% of the staff reported missing more than 1 shift a month because of illness, and again, that was more than double the rate of the Hamilton staff. And we know, so just distilling the lessons from the SARS epidemic, the sorts of things that were found to be helpful were coordinated responses with telephone lines for the public, and also resources for healthcare staff that were needed to be coordinated and also linked with mental health services. I mean, we'll come back to this in terms of the current situation, but this is some of the lessons that came out of the SARS epidemic, and supervision and input from mental health staff, but in a sort of coherent whole was some of the lessons that came up. We've already got some initial lessons from COVID. Some of our Chinese colleagues have been really great at getting some information out into the literature of some of the issues that they've faced. And the things that have come out from Chinese colleagues are certainly that staff represent the needs as particularly related to physical needs, access to PPE, although actually in the Chinese studies the fear of contamination didn't seem to be that high. It may well be that they had different levels of access. Support staff to help with tasks, and rest areas were key things, and accommodation. They also reported staff that struggled to actually manage difficult presentations from patients' anxiety. And I think we'll come back to this point about how patient relative well-being and staff well-being can't, they have to be considered together. So those are some of the lessons, and this is just some anecdotal accounts that I've picked up, and I'm sure people have seen on social media. So this was in fact a colleague in Spain who I had some conversation with over Twitter, and he was particularly talking about the demands, obviously the demands on clinical care, but the sort of effects of communication with relatives, and he was highlighting the difficulty of keeping relatives in touch, and then the feelings of being unable to perform adequate care. And that was even illustrated more strongly in a post that was on social media just this weekend about a nurse who reported feeling extremely distressed by having to tell the family of somebody who was dying that they couldn't go and see him and say goodbye. And just, you know, that obviously having an effect on the relatives, but also on the staff member themselves. So these are some things that are themes that are already coming out, and we'll come back to these, I think, as we go on. So I think I'm handing over to you here, aren't I? So I'll hand over to you.
Over to me. And I guess that the reality is we have learning from SARS, we have learning from COVID in China, Italy and Spain. But some of this we're kind of estimating, and we're trying to work out as we go along. But what we have is a sense that this, you know, the idea of this sort of flattened curve, etc., that the virus will peak and then it will trough. So the demand on healthcare services will peak and then it will flatten out in terms of acute front line. But of course, there is then the kind of knock-on effect of all of that. So everything we're cancelling now, we have to pick up further down the line. So it's not really a smooth peak and trough. But what we did know is that the psychological responses are going to vary phase by phase. So for those of you who saw the document I produced on the 12th of March, which feels like about a year ago, for the Intensive Care Society, I had 5 phases in this, but we've kind of brought it down with the expert reference group into 3 phases, and really the action phase is the active phase is kind of 2-parter. So what we know is in all of this preparation, people have been kind of pushing to kind of get going, get prepared, and adapting really quickly what we have in our healthcare system. And so with that comes just high stress, anticipatory anxiety, but also a little bit of excitement. Isn't it interesting when you push healthcare services, some of the systems that are really quite clunky actually can be pushed on with the right kind of resource. But what we do acknowledge now, everyone's in a slightly different place in the UK, and people listening abroad might be in slightly different places, but we're pretty much aware that most UK health trusts feel like they've done the preparing, and actually they're exhausted with preparing, and a lot of people are getting going or on that cliff edge, kind of can't wait to get going. So kind of moving more to the active phase, we're kind of anticipating that we'll see 2 halves of this active phase. So there's the first part where actually it's the come on, we can do it kind of feeling, where actually people feel like they can step up. And I think a lot of ED, ICU colleagues, some colleagues from theatres feel like they're built for this, actually. So there's this sort of sense of rising to the challenge, but in rising to the challenge and rising quickly, we respond on instinct, and that affects our thinking, and starts to kind of wear away at the edges a little bit. So thinking about loose boundaries, I as a psychologist would never have responded to a WhatsApp at 10 at night from a consultant, but that's what I was having to do last night. So the kind of social norms and things that we would normally do start to slip. And also we start to see some interesting behaviors that we've certainly seen in supermarkets. We see the same kind of survival behaviors starting to emerge as people are trying to get things done. So what we know is as we move through this active phase, that this is a long haul. You know, that line, this is a marathon, not a sprint, that was in my ICS stuff, has gone out there quite a bit. So really what we're expecting in this kind of next part of this active phase is that people will start to get worn out with it. People will start to kind of question what's going on. And I think, have we got a next slide?
I think you're going to pass over to me at this point.
Okay,
yeah. So before I do that, I just want to, this picture I put here because I think it's really very illustrative of this. So Dina Asher-Smith is just obviously in the action phase, sprinting, but the focus is so clear in her eyes, and I think that's where people are in the action phase. And sometimes that tunnel vision that you mentioned, Julie, can, you know, sometimes you would be able to solve a problem or think what to do, but just you don't have that kind of ability to step back. And I think that's something that the sort of, you know, sometimes just stepping back for a tiny bit can be helpful in that phase, and we'll go on to that.
I think what we've seen within that is just such a huge surge of information that people are overloaded already.
Yeah, well, actually, that's another thing with this picture. Sort of going on about this picture, but I think, you know, you're running that fast. Everything else is a blur, and I know my email inbox is a complete blur. I can't read emails because in fact, I just responded to someone in the BPS this morning by saying, I can't read your email; it's too long. And it's, you know, you get into that thing.
I've done that
and
too.
I think, you know, staff are very much in that mode, and I think those other people who are sort of relating to people in that mode need to take that into account. So the trouble with this action phase is that sometimes it can be a long road, and the track runs out, and then you start going into the mud, and then it starts getting a lot more hard going, and in this phase of disillusionment and exhaustion really starts to set in. And this, I think, you know, Judy's identified as an area of particular kind of psychological challenges can arise. And you know, people are on that automatic pilot and going, but then suddenly exhaustion can hit quite suddenly. And the effects of neglecting physical and psychological care can obviously have kind of a knock-on effect and a cumulative effect. The other thing that we've highlighted in the guidance and has been highlighted very helpfully in some other guidance, Neil Greenberg's guidance really focuses on this, is moral distress and injury. As some of the conditions people find themselves in, and then again acting sort of, you know, in a sort of automatic mode, suddenly people find that that's conflicting with their basic sort of ethical values, and sometimes sort of too late. And so it's, you know, we'll come back to this about how to keep those in mind, even though clearly it's a challenging and, you know, different situation in which you're applying them. And so the final phase in the sort of this idea of action, preparation, action, recovery is the recovery phase, and we'll certainly go on to talk about this a bit more later. But I think the things that we want to emphasise here is that people, well, the first thing I think is really important to emphasise, that most staff will feel able to cope successfully using their own preferred style, and that might look very different for different staff. There may be some differences if you looked at staff groups as a whole, but you know, it's important to recognise that people cope differently and draw on different resources. So, you know, it's definitely important not to have a kind of one-size-fits-all model, and many will be changed in a positive way. I think we wanted to just make a note of, you know, at this stage, sometimes people start to ruminate and think about what they should have done differently, and you know, in healthcare, we often have situations of things that are sort of traumatic, and then after the event, we start going over it and thinking about what we could have done differently. And you know, sometimes that's necessary, sometimes it can become unhelpful, but that can, you know, sort of related to shame and guilt. And I think, you know, one of the things we're aware of is that there is a national heroes narrative around healthcare staff now, and that will be throughout this crisis, which, you know, that's clearly, you know, that's not going to change, and it's got lots of positives to it. But for some people, that might create a bit of a sense of dissonance and separation, and I think it's important to be aware of that. And it may be important to sort of have spaces where you can move away from that and be a bit more open. Staff can share a bit more openly. You know, particularly one of the things with moral injury is then a sense of resentment towards the organisation, either at a local or national level. The sort of snowballing of the impacts we talked about earlier, the changes in behaviour, withdrawal, avoidance. I mean, some of the sort of traumatic symptoms can lead to avoidance, to avoid the triggering of that, and that might at extreme mean you know, leaving the work environment, but also can have triggering effects on family relationships. Stress can cause sort of difficulties in family relationships and also social relationships, and of course that can just exacerbate things further. So it's like a sort of snowball building up, and certainly some staff will have chronic difficulties, which you know, will then become sort of self-perpetuating, and that, you know, we think the most sort of prevalent one will be burnout, compassion fatigue, and moral injury. But also we certainly know that a proportion of staff will also experience post-traumatic stress. So I think the point. Oh, did you want to come in?
Oh no, you carry on.
So I think the point that I think we really want to emphasise through this guidance, well, there's lots of points, but one point that we want to emphasise is that psychological needs of staff is not something to think about just at the end of all of this. So it's not a case of really just going through this and then at the end of it, we kind of, you know, think about the psychologist to come and pick the staff up, because, you know, there's a lot that can be done at each of those stages to protect psychological well-being of staff, and you'll see that some of it's quite practical and doesn't involve, you know, lots of psychologists going in, but it's really important to be thinking of psychological well-being of staff all the way through, I think, is a point that we really want to make, and not just sort of thinking about, well, we'll pick up, you know, any sort of fallout at the end of it, we'll collect that up and deal with it at the end, because it can be prevented. I think that's that, you know, there are things we can be doing now, actually, as in, you know, as soon as you finish watching this webinar, to mitigate and reduce the risks of psychological sort of difficulties in staff. I'll pass back to Julie. So we're going to start with the first 3 recommendations.
Okay, so in essence, the 10 recommendations are recommendations for looking after staff well-being in any kind of situations, but now everything else is ramped up, stress is ramped up. These are more important than ever before. Leadership, we know, is massively linked to employee experience and employee well-being, but one of the things that we particularly recommend within leadership at the moment is accessible and visible leadership. This is unprecedented. We don't expect you to go around with the answers, and I think often people in leadership positions want to go around in a can-do, problem-solving way, but I think sometimes just showing up and showing that you're in this with your staff and that you're struggling with this. I think also for psychologists to not sit back and wait for staff to come to them, but in reach and show that visible leadership as well is really, really key. I think 2, really think about communication. I right now am overwhelmed with information coming in from all sources and all different mediums, and I think, you know, it might feel for some the horse has bolted, but there is still time to pull back and think about that systematic way of communicating with your staff. So I, on our ICU, really early on started these staff bulletins every couple of days that we share with the staff, and basically they look forward to seeing it because they feel really in the loop. So really think about how you're getting information out there in a trickle feed kind of way. But a hugely important thing, maybe that should have been number 1 in many ways, is the access to physical safety needs, because actually if we think about this as a whole, and if we move on to the next slide, David, actually a really big part of this is it's pushing our threat systems. All of us feel somewhat, to some degree, unsafe with this, and if we can't get the physiological safety, the physical safety right, then we're going to really struggle with the psychological safety. So I know people think, gosh, PPE, what's everyone complaining about? But it's incredibly important that we are protecting our staff through and through. But we also need to think about the fact that they can't get time off to go and buy a sandwich. Are we taking food into them? Are we hydrating them? Are we making sure that they're getting their breaks, etc., etc.? We need to think about those basic needs being met. And I know in my own health board, they're doing things like putting up hotels and things like that for staff as well, because a lot of staff don't fear infection, they fear infecting others and need to be away from elderly relatives, etc. So the physical safety is absolutely paramount to promoting the psychological safety, and sometimes that being present as a leader and putting things in place for your staff actually can alleviate a lot of the extra things they have to think about and actually really help them to feel a bit more grounded.
I think we need to probably speed up a little bit, Julie, given the time.
Yeah.
But I just make the point that it works in the other way as well, that psychological health also has an impact on physical health and also clinical care and physical safety.
Yeah. Okay, so thinking about the other things that are really important, a lot of what's happened within coronavirus is disconnection, and it's really important that we think about how we can ensure peer support and human connection in any way. So, you know, things like certain people might be losing staff rooms right now because they're being taken over with storage and things like that. We must be very careful to protect space for staff to connect with each other. I think the thing that we've certainly learned from Wuhan is that the patients and the families who are coming in are absolutely terrified, and that is something that's just a bit too much for the staff to handle. They've already got a really narrow bandwidth, so they're struggling to handle this. So actually this is where our psychologists can come in and help with strategies to manage patients and family anxieties in order to take another burden away. In terms of everyone's psychological responses, it's very important in terms of normalizing. This is unprecedented. We do not expect people to hold in their distress, and it really is okay to not be okay, but it is distressing to witness your colleagues being not okay, and it is okay to acknowledge that in yourself. I think it's also worth knowing that if you're feeling okay right now and wondering what all the fuss is about, then maybe you were built for this, and that's okay too. But there will be people who will need extra help. And I think when we think about our kind of ways of checking in and delivering psychological care in stepped ways, if we go to the triangle in the next slide, we can take you through the way in which we're suggesting that you deliver psychological care. So those basic needs being met. The next level is making sure that the information that we're sharing with people is clear, but we're also giving them access to online things, short video clips, one-page how-tos, those kinds of things, so that they've got ideas about psychological well-being, and then provide some in-house psychological support at a first aid level. So often a kind of rapid access, one-off check-in, bring down from the ceiling. And then for some people, they'll need much more of a sort of monitoring approach. Let's check back. You had a traumatic day at work. Let's check back and see how you're doing in a couple of days or a couple of weeks' time. And there will be a small proportion that will be able to access and actually have the headspace to make use of psychological intervention right now. I think a lot of people who will benefit from more of an ongoing approach are the managers, the people managing a lot of distressed people. And that lovely quote from Wuhan there, many staff mentioned they didn't need a psychologist but needed more rest without interruption and enough protective supplies.
Okay, and just the final three recommendations in this phase. We recognise that the environments people are working in, particularly if some staff are working in that some of the big sort of mega units that are being built are going to look very different to how care normally looks, and the pressures people are going to be under are going to be different. But so it's going to be necessary to innovate to implement psychological care in a coordinated way, but it's really important to do that, and it needs to obviously be within organisational policies, but trying to put the principles of compassionate care. And I think, I've seen some examples and talking to colleagues about, trying to look at using mobile phones for patients to communicate, using windows that the relatives can view through, just being creative in the environment, but just recognizing that, psychological care is often, about just a connection, and it may not be the frontline staff that have to deliver all the psychological care themselves, but knowing that it's being delivered, I think, can relieve the burden. And like that quote from the nurse earlier, it's knowing that there is that connection between relatives and information flowing. Julie will talk about using information line for relatives. Just knowing that that's happening can be really important. So just being, having some sort of innovation. There was an example on the news of a healthcare assistant in Spain that had taken on herself to put on Twitter that she was taking messages for relatives and delivering them because she was working in the hot zone. And just, it may look different, but just that, just thinking about that connection and how you can keep that up and that compassion is so important, even though it will clearly look different under challenging circumstances. And again, in decision making, just coming back to the core NHS values and thinking about how we can operationalize them in this situation. It will obviously look different, but we still have our core NHS values, particularly compassion, respect and dignity, and everyone counts is one of the core NHS values. And just thinking about how, not losing sight of them completely, just trying to keep them in mind and how we can adapt the way we work to put them into practice. And the last one here is, as Julie mentioned earlier, take care of yourself and pace yourself. And we know, sadly, we know that this is not going to be over anytime soon. It is going to be a long haul with COVID, and it's really important for us to pace ourselves. And this little image here is Eliud Kipchoge, who, as you probably know, was the first person to run the marathon under 2 hours. And I like this picture because when he did it, he didn't do it on his own. He didn't do it even in a race. He did it surrounded by people who were setting the pace for him. And I think that's a really nice example that how we're going to get through this is by, working together to make sure that we all pace ourselves. And when we were talking about this earlier, Julie was saying, well, actually, maybe the role of psychologists can be to help set the pace for other staff. And I think we're needing to rely on each other, and setting the pace for each other is a really important point.
I think someone needs to help with the rapid speed of everything going. We need people around who can sort of slow down and take the thinking space and work some of these things out, because people's ability to problem solve is rapidly going. So I think quickly, but very importantly, is that the peak may ebb off for the virus and the incidents, but actually the psychological peak may maintain, and the recovery may take a long time, and long time, we're talking kind of a couple of years, really. I think, people will need to take stock and to kind of make sense of what they've been through, and to kind of reflect back. I think it's when people kind of pause and realize what they've been through that some of the impact of this will hit. But some of that actually, and there is certainly a role for psychologists facilitating that, but I think some of that actually will come to positives as well, and learning, and kind of some of the things that we learn from this will be about actually systems that were never fit for purpose in the first place, and kind of really getting your staff involved in that. And I think also the thanks and the rewards, and be very careful of the kind of hero worshipping one-offs. Much more of the thanking everyone for pulling together is incredibly important. And ask your staff towards the end of this, when we're sort of taking stock, what do they need now? Ask them to tell you what they want access to. I think quite likely there will be a few people who are then in that reflective phase and able to access their in-house employee wellbeing services. If you don't have them, then you should be maybe developing them internally now, not helicoptering people in necessarily, but building this into the system for future resilience is a really, really good idea. And just thinking about networks and peer support, and how nurses, therapists, doctors are very good at kind of buddying up and supporting each other. So making sure that we're kind of maintaining and expanding those systems too.
Great, thanks. So there's just some, we've skirted over quite a lot of, we've sort of touched on literature that's been produced. There is some really good stuff that's come out very recently. So you might want to just take a screenshot of this, or if you're obviously watching it back, you can just slow it down. But we'll move on now to open up to some questions. We took a tiny bit longer than we had planned for the presentation, but hopefully it's been useful. But we'll move on now and take some questions. So we're going to also rely on, or draw on the support of Teresa Jones, who's another member of our panel, who's a clinical psychologist who's got a lot of experience working internationally in medical emergencies. And Catherine Scott, the Director of Policy for the BPS, is going to help with sort of organising the questions, of which we've got, how many questions we've got? 47 open 47. Questions. So, yeah, do you want to fire away, Catherine?
Certainly, thanks, David. I've been trying to pull out some themes from your questions, and I think the first one, just to sort of give you a straightforward question, is what would you prioritise in a service where there's competing resources? What would be your top priority? To Julie.
Top priority, what, out of the list of 10 or out of anything at all?
I think, what would you prioritise if you've got limited resources?
Goodness me.
I would say
that's a really difficult question, because if suggesting that you would prioritise one thing over another is kind of the biggest kind of moral distress thing right now. So if I'm thinking in terms of priorities for just people's psychological well-being, physical safety, absolutely, that would be my number one.
And I would say, I think to be important, I mean, both within the BPS coping with this and within the NHS and within the country, actually, we can sometimes think, oh, our resources are very limited, but sometimes it just means a sort of opening out our scope a little bit and thinking about how we can draw on resources that we hadn't thought of before. I mean, on the news last night, there was the thing about testing capacity by using universities. And, you know, in the BPS, we're using, you know, what the example of how Teresa is on here is that Teresa responded to a tweet that I sent with the original diagram, and we got into a conversation, and Teresa was just an amazing resource that I wouldn't have thought of if I just thought, oh, what's our BPS resources? And so I think you do need to open in a crisis. You need to have a, you know, just be a bit more open to thinking about where the resources are that we can draw on.
So probably a second resource to protect as much as possible is thinking space, so thinking outside the box. We're terrible at just thinking in terms of the box and our rigid processes in the NHS. So actually preserving some headspace and time for people in key positions who can kind of do things like get in touch with different people, read the research, kind of connect all of these ideas and innovate and change systems rapidly.
Absolutely. Okay, we better try and get through a few more questions.
Get some more.
The next question is sort of linked. It's around how do we balance the kind of priorities of needing to wear that physical PPE versus sticking to some of our psychological best practice in terms of creating relationships and building relationships. There's a few questions around kind of how to balance that tension.
I think Teresa might have something to say on this.
Yeah, no, sure, thank you, and thank you very much for having me on the panel as well.
Oh, thank you very much for being there. Can't see you, Teresa. Are you? Or is that?
Oh, okay.
I don't want to force you to put your video on, but
no, I can.
Ah, great.
So the question is around balancing the need to wear quite heavy protective equipment, but also to create connection and to humanize the relationship between people involved in healthcare. And we see this in lots of different health emergency settings. So having worked in the Ebola context, that's certainly a big issue. The protective equipment is quite extensive there. And I think part of that was really working on good communication skills. It was working on things like having your name on your equipment, even having a picture of you on your equipment, to use touch as much as you can, because in that case, if you're wearing full PPE, that's still very possible. And also some of these new innovations using mobile phones, using screens to be able to connect patients with families has been really important as well. But it is difficult and it is tough, and it requires, during training around infection prevention and control, is also integrating these elements into that training. So it's not just about wearing the equipment, it's about using it as well. And I think we also underestimate how scary it is for patients to be in that setting surrounded by this equipment. So to really keep it in mind what the experience is like for them as well has been really, really important in other contexts, and will be the same now.
Brilliant. Thanks so much, Teresa.
So the next question is around specifically working on mental health wards. There's a number of questions have come from people who are working on inpatient mental health wards with patients who experience psychosis and paranoia, and how this has increased quite dramatically since COVID. Is there any sort of suggestions you can make specifically for those on the webinar who are working in those services?
Over to you, David. I'm in ICU.
Well, my background's in working in acute settings, so I don't know if Teresa's got anything to say on that.
I can maybe add a bit, just in case for us to think about what basic needs might be in this situation. So if you're already confused and distressed, and then suddenly this environment around you becomes very different, I think there's a need to really think about orientation, helping people know where they are, what's going on, to the extent that needs to happen, but just to kind of think, what are the basic needs here for the patient? I think that would be really important in more of an acute mental health setting.
I think maybe if you then extend that into kind of, if you're thinking about kind of dementia wards as well. Someone was asking me this week about labour ward. Everyone's anxiety is ramped up right now, so thinking about those basic needs kind of across.
I think in that sort of a broader point about that we very much got in mind is that the impact of the COVID crisis, is not the same for everyone. There's a relationship between the COVID crisis and people's own sort of individual backgrounds, and people with particular backgrounds are going to, have particular challenges. So in the BPS work, we're doing work on different streams: children with special educational needs, people with autistic spectrum conditions, and just trying to think about how their needs and the COVID crisis kind of can be managed together. So I think it's very important not to kind of just sort of extrapolate our own experience of the COVID crisis, or even out of hospital, just being at home, and just kind of extrapolate it to everyone else. We do need to think about what the experience of different groups is. Probably time for I've lost the track of the time now. Are we strict in terms of timing till Q2, or can we go on a little bit longer? Somebody?
I think we can go on a little bit longer. I do have a few more questions I could put to you.
Okay, well, I think we're all happy to go on a bit longer. Yeah. So, and we won't be offended if any participants.
Yeah, we've still got 1,000 people on the line, so
okay.
let's get through some questions.
If it gets down to 10, then we'll know that
There's a few questions around what can we do around supporting the well-being of staff in the sort of wider NHS. So thinking about people like GPs, community pharmacists, and other support staff. What can be done particularly around their mental health and well-being?
Well, I'll jump in and the others can pick up that point. I mean, I think that's actually what it's good to pull it back. And certainly when we're writing these guidance, I'm just going to even broaden it out even more, because when we're writing this guidance, we're particularly aware that it's very easy. And if you look at the coverage on the news, it's very easy for people to just focus on doctors and nurses and think about an acute setting, to think about those as the people who are at sort of risk of psychological sort of consequences of this crisis. But we know from experience and from research that actually the effect is much wider. Within hospital settings, there are other staff groups that are equally affected, and often don't get so much attention. So that be portering staff, catering staff, radiographers, physiotherapists, and admin staff. I mean, some of the research that's coming out is showing that the admin staff and people who are having to actually be outside the hot zone and relate to relatives and take calls from relatives are actually under more pressure in some ways because of that aspect of it having falling on them, and so obviously again even wider than that are people in pharmacies and GPs who. So I think the principles of what we're saying definitely apply to all groups, and I think it's important to recognise that and to think about obviously how it might be operationalised might be different in different settings. I don't know if you want to come in, Julie.
So I think one of the interesting things from Bob Maunder's work is that the ED staff, the ICU staff were less traumatized than the peripheral staff. And I think the thing is that ED, ICU, you simulate this stuff all the time, maybe not at this level, but you choose this area because you like this high pace, high risk work. And I think it's the areas that are not used to experiencing high pace, high risk, death, distressed relatives. They're the ones that we need to worry about in terms of kind of how do we skill them up rapidly in that. And I think that's where that help in terms of supporting the patients and the families, so helping them to manage that, making sure things like the physical needs and the breaks and the sort of down regulating is really, really happening there. And I think the information and the communication is really key for these people who are not maybe not able to process this information at such a high level, and maybe they need things kind of spelled out to them in different kinds of ways to enable them to really understand what's going on and make sense of their own personal risks and look after themselves in this.
I think that's right, and I think there are individual sort of factors, but also then there's sort of peer support can be more of a challenge in different settings, can't it? If people are working more in isolation, so I think even we talk about being flexible, but having a systematic approach to peer support, and I think that may be even more important for people who are don't have such an immediate sort of peer support network around them. Okay, should we try another question, Catherine?
Yeah, sure. So there's a specific question about debriefing. So do you feel that there is a need for structured debriefing as opposed to unstructured debriefing to provide a safe space for colleagues to collect their thoughts and learning themes after shift? Or do you feel that this may do more harm than good?
So I'll take that and say, if you read the guidance, there's an embedded link that tells you exactly what you should and shouldn't do around debriefing. Debriefing is a bit of a controversial term. There's kind of mixed messages about how it's how effective it is and the impacts of it. And I think that the most important things that I say, it's very hard to get rid of the word debrief because my clinical colleagues love to use it.
And it
But
has a different meaning now,
I
doesn't
actually
it?
tend to say detox, don't debrief. So in a way, let's think about storytelling, sharing experiences in a voluntary way is really important, with the right kind of person listening, but actually enforcing structured, you must turn up and we'll go through this in a certain kind of way. That's the stuff where the riskiness lies. But rather than go into the whole detail of that, look at the document, follow the link about traumatic events and the do's and don'ts.
Right.
I will just add as well, from a global mental health level, debriefing has again been a controversial topic after emergencies, not just health emergencies, but other emergencies as well. And I think you probably noticed in the document the reference to psychological first aid, and that has been used as an alternative approach.
Yeah.
And that's really looking at promoting safety, stabilizing and connecting individuals to help and resources. And again, this might be very practical help in the moment, listening to what people need and connecting them to those needs. You don't need to push people to tell the story. And this approach, it's gaining an evidence base. There hasn't, because of the limitations in emergencies, been any RCTs. But if you do some reading around this, and there's a very good WHO link that we can maybe drop in the window, or we can circulate to all participants, that will share a bit more about it.
I think it also comes back to the point that we made earlier about individual differences in coping. And over my kind of 30 years, I've often been called on to sort of come in and sort of respond to a situation where staff have had to cope with something very traumatic. And, you know, with in that situation, my first thing is, if speaking to someone individually, always to say, you know, what normally helps you in times of sort of crisis. And, you know, people have got things that they've found helpful before. And I think going in and sort of imposing things on people is, you know, it's not surprising we found that not helpful. And I think, you know, it's already starting to build on people's strengths of what's been helpful before. And it does look very different with different people, but can be equally effective. So, you know, we know that with patients in healthcare settings, that people cope in different ways. I mean, there's a very long literature on how you're matching sort of the way, sort of technique to help people cope with difficult, stressful procedures depends on their coping style. And, you know, it would, you know, at the end of the day, staff are people as well. We're not a different kind of species. So that you know, I think it's an important thing to think about individual differences and people's own coping strengths in any of this work.
I think, as a rule of thumb, for anyone who's not trained in any way, just asking, hey, that was tough, are you okay, is actually a really, really important thing. Acknowledging and giving people the opportunity to talk, but not making them feel that they have to talk, is very, very key.
Yeah, great.
Okay, we might make this the last one as we're coming up to the hour, and you may want to wrap up, but there's just variations on a theme of how can I help, and I think, you know, we've got everybody on here from undergraduate students, we've got people who are working in other parts of the healthcare system, we've got people who are volunteering with community groups, and just a general question about what's the most valuable thing that they can contribute.
I mean, I'll start that, and I think Julie might come in. I would say, I think, again, to some extent, you know, I think there is an instinctive kind of rush to sort of action with this, and you know, within the group, we kind of rushed in and came up with the first version. Then we took a step back and thought and said, well, you know, what are we trying to do here? What's the aim? Who are we trying to help? Who are the people that actually, you know, we can make most impact with, and that was a really important process in the guidelines, because we started off on one angle and came back, and so I think it's the same thing in for individuals to think about, well, what do I bring to this sort of crisis? And it might be, I mean, you know, people can have a lot of psychological skills, but it might be other kinds of things that you can bring as well to the situation, and take a step back and think, well, who's around? What can I actually, you know, who can I help with? And, you know, I think a lot of us at the moment are, connecting with people that we maybe haven't connected with before and saying, is there anything I can do to help? And I think that's helpful. And also just looking around us, there might well be people living next door who could do with the help, and actually we can make a big difference by going to Tesco's for them. So and it may well be that there's things we can do within our job settings differently and reaching out to people, but I think it's about listening to what people are saying they need and not imposing, jumping straight in, and also thinking what we can bring. So Julie has probably got something more.
Yeah, I mean, I'd agree with all of your points. I think what I've seen is a surge to rescue psychologically, and thinking that the answer to that is a psychological intervention. And I think let's be very careful, because that kind of says that we don't want to see you upset with this. And actually we know that this is going to be a really stressful period of time. And I think what you can do to help now are the kinds of things that David are describing. I think, a lot of psychological services are reshuffling themselves in terms of their capacity with things that have been cancelled, and trying to reshuffle to create some capacity to help. And that, there may be local people who can add and buffer that capacity. But actually, given that this has only been about sort of a 3 weeks, a month or so, actually organising lots and lots of volunteers is actually a hindrance right now. So we need to be very careful about lots and lots of people coming in now, when this is a marathon, not a sprint. So let people organise themselves, get themselves in line, and then actually you'll find that there's probably stuff over time that emerges that you can be helpful with. But the first thing you can do right now is probably buy a box of eggs for your neighbour, actually, and those kinds of things. So think small, don't think global too much with this.
And I'll just come in, and I think this might be a nice point to wrap it up, actually, because I think it's helpful to take a step back and think, well, what's behind me trying to sort of rescue? And often it's our own distress. And I think it is worth us all recognizing that the distress is not just out there, whoever we are, whatever our backgrounds, whether we're medics, nurses, psychologists. The distress isn't just out there. This COVID crisis doesn't just affect everybody else, it affects us as well. And I think recognizing that, for me personally, I've got an elderly mother who I worry about. I've got my wife with medical conditions, and people I know. And so it's about recognizing that it does affect us as well, and we need to think about the impact on that and manage our own self-care and manage our own psychological well-being, because again, we're people as well. And so I think that's an important thing to bear in mind, and take care of ourselves. And it is a marathon, not a sprint, even if it feels like a sprintathon at times. We need to pace ourselves and look after ourselves. So that's probably a good as any point to finish on. So I hope this has been helpful to people. Do keep the conversation going. We've got the Twitter hashtag. I think we've been sharing, I don't know if we've been able to share some things, but we'll certainly share as much as we can. And it's obviously an ongoing process. So this isn't just all of the sort of input that BPS is going to give. There's going to be other resources and webinars and things. So I hope it's been helpful, and thanks for your time, Julie and Teresa and all the BPS staff in helping, and everyone who's joined us online. I hope it's been useful for you, and take care, stay well.